Hey, good morning and good afternoon, everyone, and welcome to today's webinar entitled Tackling Malnutrition in the Primary Care Setting. As Sam informed you, Rater today, and my name is Cindy Steele, and I'm the Medical Affairs Manager with Nestle Health Science. We've had such an incredible response to this webinar invitation with over 640 registered across Canada. This validates for us that this is a really relevant and very important topic for Canadian healthcare professionals. We are fortunate to have the Canadian Malnutrition Task Force that spearheaded so much of the work on malnutrition in Canada to date. And we're also really fortunate to have clinicians like our speaker, Michelle, who are dedicated to ensuring that we aren't missing individuals who are malnourished or at risk to malnutrition by incorporating some of the key learnings from the CMTF and making them relevant to other care settings. If you ever get the opportunity to speak to Michelle in person, you know she is passionate about this topic and about advocating for the team approach to malnutrition care. Just want to remind everyone that the handouts are available throughout the presentation in the panel to the right of your screen called Handouts. And I now have the pleasure of introducing our presenter, Michelle McDonald-Worstek. Michelle is a primary... I'm going to actually read your bio. That's okay. Michelle is a primary care dietitian working with family health teams in Ontario for many years, including the McMaster Family Health Team and the Hamilton Family Health Team. She brings more than 25 years of experience and a true passion for her role as a family health care team dietitian, providing nutrition counseling for patients, nutrition knowledge and support to her teams, and nutrition education to future health professionals. She is currently an associate professor with the Department of Family Medicine at McMaster University and also chairs the Dietitians of Canada Primary Health Care Action Group, which is a group of dietitians sharing best practices in primary care nutrition. So with this, I will hand the controls off now to our speaker, and I'll be back at the end to moderate the question and answer section. It's all yours, Michelle.
Thanks so much, Cindy, for a lovely introduction. And thank you to Nestle for giving us this opportunity to spend a little bit of time together to talk about an important issue that currently falls under the radar. So I'm forwarding the slides here. Do I have the slides? Let me see. Sam, I can't seem to forward the slides. So hopefully Sam can help with this a little bit, with assisting with the slides. So as Cindy mentioned, I'm actually from the Primary Healthcare Action Group, and I chair that group of dietitians that are representing dietitians from various settings across primary healthcare. And our efforts are really to try to share some of the best practices and really measure the outcomes of nutrition services in a variety of primary care settings. And I wanted to show you a little YouTube video. Sam or Cindy, can you guys help with advancing the slides? For some reason,
unmuted.
Nutrition that we're finding. Okay, there we go. And when we actually look at some of the consequences, we see an increased risk of falls with many of our folks that are malnourished, as well as an effect on quality of life, as well as worsening of some of the chronic diseases that many of our patients present with. In addition, we're finding that there's huge costs to the healthcare system. So when we look at the Canadian hospital budget, about $25 billion budget, about $2 billion of that is attributed to malnutrition in hospital settings. That tends to lead to higher costs since malnourished folks tend to stay in the hospital much longer and have multiple complications, and then are also associated with a very high 30-day readmission rate. So before we get started on our talk about malnutrition, we wanted to give you a little polling question. And if you have a minute, please take the time to answer this question. What is malnutrition? Is it option A, malnutrition includes both deficiency and excess of macro and micronutrients? Option B, often referred to as undernutrition. Option C, a hidden epidemic missed in hospitals and community settings. Or option D, all of the above. We'll give everyone a minute or so to vote. So do we have our poll? And everyone's correct. So option D is the right answer. It definitely is a hidden epidemic, and it definitely seems to be affecting both excess and imbalance of nutrients. So when we start to look at some of the evidence that malnutrition is happening, but somewhat hidden and not on our radar, some of the evidence we looked at was from StatsCan, and StatsCan did a review of nutritional risk of seniors in Canada and found out about 1 out of 3 seniors are at nutritional risk, often more common in women and associated with other risk factors for malnutrition. And we know that nutritional risk increases the risk of falls. In fact, a malnourished senior is 73% more likely to fall than a well-nourished senior. Looking at some of our hospital data, our recent Canadian Malnutrition Task Force data looked at 18 hospitals across Canada and found that 1 out of 2 adults going into hospital were being identified as malnourished. And those patients tended to worsen during their stay, stayed 2 to 7 days longer, and were associated with the high 30-day readmission rates. And in family practice, what we're finding is many of the patients being discharged aren't being identified as malnourished, and often this is being missed in family practice. But yet there is good news. So the evidence in the literature does show that nutrition support does improve outcomes and can provide adequate nutrition to help improve and reduce complications, can reduce mortality rates, and this is from the hospital literature. And in the primary care literature, there was a recent systematic review by Howardson that did a wonderful job at looking at how nutrition supports can actually improve patient outcomes in terms of nutritional status, functional status, quality of life, falls and hospitalization rates. And it seemed to save money doing it. So every dollar spent on nutrition intervention in the primary care settings saves the healthcare system $5 to $99 by reducing hospitalizations, medication costs, and freeing up physician time. And family practice is one of those areas we need to be focusing on, is how can we detect issues at an earlier stage and intervene in a more timely manner. And in fact, when we look at the literature on seniors with malnutrition, they do tend to have more visits to the family practitioner, and they have more of a medication use and a much higher rate of admission to hospital or long-term care. In terms of feasibility, the research also supports that this is feasible. Screening our seniors in family practice is feasible if we have validated screening tools and clear clinical care pathways, and that training our nurses and physicians to catch early signs of malnutrition with early referrals to the most appropriate providers improves patient outcomes. And I've listed for you just a few of the articles there, but there's quite a few. We have quite a list actually in our library. So despite all this evidence showing that there's a high prevalence of malnutrition and that yet nutrition support and team-based care makes a difference, we did a survey in 2015 of dietitians working in family health teams and CHCs in Ontario, and found that of the approximately about 406 who replied, we had very low rates of referrals for malnutrition nutrition counseling. And we were trying to identify who we were seeing and the populations that were currently missing. And this was one population that was identified as very, very few referrals. So for that reason, our action group, which is again a group of dietitians across primary care settings, we decided we were going to focus on malnutrition as the first part of our Reaching the Most Vulnerable Population campaign to really help create the tools and provide training and mentorship and clinical care pathways that dietitians and other IHPs could use to advocate for screening within their practice settings. And our focus really was on keeping seniors healthy and out of the hospital, and by detecting malnutrition in family practice. And this is our acronym that we came up with, SCREEN being the short form, Screen Seniors for Nutritional Risk, chart risk factors, R for refer to appropriate providers, E, educate patients and families to correct and prevent malnutrition. E also stands for evaluate our outcomes, and N is create a network of support, both within the family health team setting as well as linking with our community partners to facilitate some of the care coordination across settings. And this is our toolkit. So we created our malnutrition toolkit, and it's accessible through a shared Dropbox folder. And in this toolkit, we've tried to gather all of the information, the evidence that supports and advocates for why we should be looking at this vulnerable population. We've created advocacy tools, we've put in slides, we've chosen screening tools that are appropriate for community care settings, and we've created a variety of different clinical care pathways that demonstrate how screening is happening at different locations throughout the province of Ontario so far. A key part of this was to help standardize the screening process and the documentation and be able to collect outcomes. And so for that reason, most of us in Ontario use an EMR system called Practice Solutions. So we've created custom templates that can be embedded in Practice Solutions that actually help streamline the process and have the tools embedded within them. And in addition, we've done other webinars as well as learning pieces. So this is the slide that just speaks to the custom forms. Again, it's specifically for our EMR system that most of us use, but the intention is to simplify and standardize the process and to make outcome data retrieval easier and to share that outcome measure and advocate that nutrition screening really should be a quality indicator on our reports that go to our directors and the ministry. So far to date, we've been pretty successful with training. We have over 250 dietitians and IHPs have attended a variety of different training sessions around the province. We host and coordinate an annual RD Research Day every year, usually in May. And we also have our annual Family Health Team Conference, and we do an event there, and we did our webinar. So a lot of time and training and mentorship went into helping dietitians and other IHPs feel comfortable starting screening programs within their settings. And a lot of that training was on subjective global assessment as well. And so far, it's been pretty successful. We have about 80, almost 90 now in the Dropbox who are doing some type of screening in the province, screening a variety of different populations, and really advocating for early detection and putting malnutrition on the radar using validated tools. Some of the populations we're screening, we're going to be highlighting for you.
Muted.
A little project that we have started as part of the action group is our 4-FIT quality improvement project across 4 family health teams. And this is really in line with our screening initiative, and it's really looking at the most vulnerable. So there's a lot of literature showing that seniors who are recently discharged are at very high nutritional risk, as well as those who have cognitive impairment. And so for that reason, we decided to advocate for screening programs within some of our clinics that we currently have, our memory clinics that we've launched in Ontario, and as well as looking closer at the post-discharge population. So screening post-discharge actually has quite a bit of literature. So when we were looking at the evidence, we were quite surprised by the amount of information showing that adding a dietitian to a discharge liaison team or adding a dietitian for 3 visits post-discharge has a strong impact on nutritional status and also may reduce the number of times hospitalized within 6 months. So really maybe something that can help reduce that readmission rate. And there's a couple studies I've added there for you. So some of the results we're seeing again, we have about 184 family health teams in Ontario, and we have about 90 of them screening. So some of the results we're seeing is some dietitians have advocated to get our screening questions added to the discharge script that nurses are using. When they call someone. In Ontario, we're mandated to touch base with someone 7 to 10 days after discharge to assess need for further support. So adding those 2 questions to the discharge script is done remarkably well at identifying seniors at nutritional risk and getting them linked with the dietitian. We also have dietitians who are doing co-booked appointments. So many of us have residents with us, so we do a lot of teaching, and we intentionally try to book our appointments with a dietitian and a medical resident or a dietitian and a pharmacist. And that seems to work very well with our discharge population because they're often coming in for med reviews post-discharge. And then some dietitians are also starting to do home visits. Again, another really good opportunity to reach out to seniors who may have a difficult time coming into the clinic, and that opportunity to do some assessment and counseling within the home. In Niagara region of Ontario, we have a great group of dietitians leading the way with facilitating conversations between family practice and hospital RDs to try to enhance nutrition discharge planning, because for many of us, if you're in the same situation, many times people are discharged and nutrition is not identified as an issue on the discharge form, nor is malnutrition. And that's one of the things we're advocating for is, can we get a checkbox so that physicians can check off that malnutrition has been identified in hospital, and so the dietitian in family practice can carry on the care plan. So in our memory clinic, so in Ontario, we have about, again, as I mentioned, 184 family health teams, and about 100 of them are part of this interprofessional memory clinic model that's been championed by Dr. Linda Lee from the Centre for Family Medicine in Kitchener-Waterloo. And in this model, again, it's seniors with mild cognitive impairment, or if some actually have Alzheimer's. So this was a population we started to look at to see, is there increased nutritional risk? And in fact, there was. We found several studies showing the benefits of a healthy eating pattern on cognitive health, and Mediterranean diet is one that has tremendous research showing how effective it is on delaying the transition from mild cognitive impairment to Alzheimer's. This was a study I thought I would put up for you because it clearly shows what many of you probably encounter, like I do, is many times patients report themselves as very well nourished when their partners rate them as not so well nourished. Or you may have one person saying, oh, yes, I eat well, and the husband or wife may be saying, oh, no, they're not eating well. So we know with seniors with cognitive issues, eating and reminders to eat are sometimes needed, and this population is definitely at high nutritional risk, and about a quarter presented with a low BMI. So what we found by adding screening to the memory clinic models across Ontario, again, in this case, they're using the mini nutritional assessment form or the Screen 2 form, which we'll talk about in a minute. We're finding that about 1 out of 3 are at nutritional risk. And when those at nutritional risk go on to see a dietitian for further assessment, about 50% or more are actually being identified with some degree of malnutrition, with an SGA of B or C. And this has led to a lot of the clinics rethinking about when they should be offering interventions. So some clinics are actually now offering a healthy aging series for seniors as a way as prevention of cognitive decline and before someone actually has mild cognitive impairment. So some of the lessons learned, we've been surveying our dietitians that are leading screening in the 4FIT study. We also survey our group of dietitians and IHPs that are in our shared Dropbox, of which is about 90. And we ask them, what's going well? What are some of the challenges? And one area that seems to be working very well is team capacity. So this was always something people were worried about when we first did our workshops. They were wondering, if there's such a high prevalence rate, as a dietitian, will I be able to handle all those referrals? And we're finding that there's fewer positives than we actually expected. So it's actually well within our capacity. It seems to be meshing nicely with our weekly schedules and not causing a lot of having to modify the scheduling dramatically. One thing that did come up, though, we did find that we're getting positive screens, but many times when our team member is screening, many times the senior does not want to go on to meet with a dietitian. And this can be for a variety of different reasons. And this is actually in the literature as well. Many of them feel that, again, sometimes as a dietitian, we might take away foods they enjoy, or they don't want to change their diet. They feel like they're doing fine. So one of the areas we want to be focusing on in the future as an action group is we're going to be helping our teams and our team members try to manage that conversation when someone is declining service to the dietitian for further assessment, including SGA, and how can we help support them so that we're not screening without an appropriate follow-up. Another great positive that's coming out of some of our reports is teams are adopting best practices. And so they're screening for malnutrition once a year. They're trying to embed that into usual practice, which is really what we've been advocating for. And another area that they've seen a great improvement is weighing seniors at least once a year and recording it in the EMR. When we first started this initiative about 1.5 years ago, we found that we didn't have a lot of weight for our seniors in family practice. So we might have been weighing them, but it wasn't either being recorded or somehow it was being missed. So when we were asking this person, have you had unintentional weight loss or lost weight without trying, it was really hard to compare when we didn't have a baseline weight. So this is something from a data angle that many of the teams who are quite motivated to start to be consistent with adding this information in. The other piece around weight and then something we need to be thinking about is watching for the different BMI ranges for seniors that are different from adults that are under the age of 65. So in fact, the literature shows that a BMI less than 23 is actually associated with negative outcomes for a senior. So that's a little bit of a different target range, which I think we need to be educating our teams on as well. Just going to go back. One more point is one of the other things to remember that, or one of the things we're finding is we're getting some false positives in our data, because when you ask a person, have you lost weight without trying? Many times our seniors will answer yes, because they think that's what they want us to say, or that's what we want to hear, because they've been told for many years to lose 20 or 30 pounds. And so sometimes they're answering to simply please us. So one of the things several of the clinics or the dietitians recommended is before meeting with the patient for an appointment, actually doing a quick phone call to almost triage and clarify that weight question in the screening tool to make sure that you're actually seeing someone that truly needs nutrition support. So we have another question for you, another polling question. This one is to see how all of you are doing with polling. Are all of you, or how many of you are actually screening seniors already for nutritional risk? And please answer yes or no. Has everyone had a chance to vote yet? And is our poll closed? Okay, it's almost a 50-50 split. Okay, great. So hopefully the next few steps will give you a little bit of information about how to screen. And this is where we started to look at the screening process, the sort of the step 1 to 7 of getting screening started. And that's really, the first question is really, who do you want to screen? So are you going to be reaching the vulnerable seniors, someone that is maybe a 75-year-old who's recently been discharged from hospital? Would you be looking at the senior population with cognitive impairment? Or would you be linking it with a service you already have? In many of us in family practice, we have clinics, diabetes clinics, INR clinics, memory clinics. Some of the dietitians have been adding the screening tools into those opportunities. Others are focusing on the well elderly, or the welderly as we call them. So there's a very high interest rate in our senior population to stay healthy and age well. And for those of us doing Healthy Aging series, we've been quite impressed by the almost 100% attendance by seniors who are attending some of these aging series. So that's another population to definitely think about screening. And really, who to screen is also linked with your goal of when or what you're trying to find out. Are you really looking for early detection and something upstream, something like the Screen2 abbreviated version tool that looks at changes in food intake and appetite and food access? Or are you looking more downstream where you're actually seeing physical change now? So you're actually looking for changes in weight and low appetite. So here's a slide that we have for you that's another polling question. And I know it's very wordy, but I'll try to read it out to you and you can vote to see if you were going to pick a population to screen, to start in your setting, who would you like to screen? Would you want to focus on the most vulnerable, maybe the frail seniors, those 75 and up? Do you want to focus on the elderly, the seniors who are in good health, but they simply want to age well and stay vibrant? Would you be thinking about adding screening to some existing services, to the dietitian visits, for example? At the Hamilton Fit, some of them are, dietitians are now screening anyone over 75 who are coming to see the dietitian for any reason at all. Or perhaps group education, perhaps you're doing a healthy heart group. Or a type of a blitz. So one of the things with flu clinic season just around the corner, there's a perfect opportunity to be thinking about screening those seniors coming in for their flu shots. And some of our northern family health teams are actually using Ocean tablets, so somewhat iPad tools, put screening tools on those, and while the patients are waiting for their flu shots, they do the screen, and the screen automatically goes into their EMR. So the next clinician who sees them, up pops their result and identifies if this person's at risk or not. Another group of the family health teams did a wait while you wait. Some of them have video cameras, so they can see when people are in exam rooms. And what we noticed is a lot of seniors weighing themselves. So since all of these people are weighing themselves anyway, what we wanted to do was get them to record their weight, and then we could transfer that into the EMR and actually track that. So that's, again, coming more from the data perspective. So how did we do here? So the most vulnerable. Okay, a lot of people are thinking most vulnerable. Some are thinking of linking with existing services, and some are thinking about a blip. So the good news is there's a variety of ways to screen. So it really depends on your goals and your patient population. So the first step is figuring out who do I want to screen. The next step is picking a tool. So there was 3 tools that we wanted to embed into family practice that has evidence for community living adults, older adults. And I want to direct you to this systematic review done by Hammer Rudin just recently in 2016. They do a wonderful job at comparing all the different screening tools because there is a huge variety of screening tools out there, and they compare all the benefits, pros and cons of each one. So with the Screen 2, there's a Screen 2 Original, 14 item, and this is the abbreviated version, the 8 item. So this is one of the tools that many of the dietitians are using across the province. And again, it's looking more at upstream changes in food intake and identifying issues, identifying risk. The beauty of this, it can also be self-administered, again, being used on these ocean tablets, or some people are using hard copy. And this is the screening tool that's on the Nutri-E screen from Dietitians of Canada. And it's also the tool that was used in the StatScan study that they looked at nutritional risk in Canadian seniors. CNST, Canadian Nutrition Screening Tool, this is a tool developed by the Canadian Malnutrition Task Force that actually is based on 2 questions. Have you lost weight in the past 6 months without trying to lose weight? And have you been eating less than usual for more than a week? This tool is validated for hospital admission and discharge, not necessarily for in-family practice. We have used it, though, for screening our post-discharge group because, again, they're being assessed usually well within a week of discharge. So we're hoping that it might be valid, but this is something we're hoping in the future to do a research study on to see if it truly is validated for family practice, because many of our teams love the 2-question approach. And then it becomes a question of process of who's going to do the screening, what's the process going to be, and that sort of ties in a lot with whether or not you want the patient doing self-screening or whether you want the clinician doing screening. Some of the tools, like Screen 2, is a self-administered or could be self-administered, versus the CNST tool and the MNA needs more of a clinician focus there as well, because that prompting around the weight measures as well. Again, all of these tools can be used, and it really is a question of your own personal choice. Once you have a positive screen, so irregardless of which screening tool you use and you identify nutritional risk, the next step is to actually determine if there's some level of malnutrition, and that's SGA, Subjective Global Assessment. This is the gold standard validated tool, and this has been around for many years, but again, the Canadian Malnutrition Task Force has updated the formatting of it. And again, this is what the dietitians have been trained to do, how to do SGA, how to assess from head to toe and define the level of malnutrition. And then if someone has been identified as being malnourished, as with an SGA score of B or C, providing the nutrition support and creating the nutrition care plan to optimize intake, correct deficiencies, prevent further weight loss, preserve lean muscle mass, and hopefully prevent further decline and manage some of the other comorbidities as well. So this is just a protocol. I don't want to spend too much time on it, but this is one of the protocols we developed for those people using Screen 2, identifying whether the person is at low or high risk. 38 seems to be the cutoff score. Once they're at high risk, though, we need a visit with an RD to actually do further assessment, including SGA. And then from that SGA, identifying, do you have a well-nourished senior in front of you who basically may need a little bit of education and off they go, or do you have someone who actually is flagged as malnourished and needs specialized nutrition care and will often need 3, 4, or 5 visits depending on what it needs to improve outcomes. And then, of course, cycling back into, we need to be checking height and weight at least once a year and recording in the EMR. Evaluating outcomes is a key part of this project, really, to show the benefit of what we do. And some of the outcomes we're looking at is how many screens are being done, how many positive screens are we getting, how many seniors are being referred to dietitians for further assessment, and of those, how many are being identified as actually having an SGA score of B or C, showing some form of malnutrition. We're also looking at pre-post measures. Is can we impact on our Screen 2 score before the intervention and after the intervention? Because the beauty of Screen 2 is it's also a diet quality measure as well as a dietary screening tool. So it functions as two outcome measures. We're also looking at, can we make a difference in the SGA score? If someone is a C, can we get them to be SGA A with our nutrition intervention? And of course, tracking weight, BMI, falls, and hospitalization 6 months down the road. So to sum it up and to leave time for questions, because this is hopefully a very popular topic, we can tell, we want to make sure you have time to ask questions. The bottom line is nutritional risk affects quality of life, chronic disease management, and increases the risk of future falls, hospitalization, and transition to long-term care. But the good news is malnutrition in seniors is preventable and treatable. The key is early detection and intervention, and working together to create a clinical care pathway that allows this to be feasible within our setting. And the bottom line is we really want to encourage people to work together to identify vulnerable populations within family practice, standardize the interdisciplinary screening and assessment process, facilitate communication across healthcare settings, and really to reinforce that idea that food is medicine and actually improves outcomes. And I'll leave you with this cute little picture that I thought was great, and the message that really losing weight and becoming frail doesn't have to be part of normal aging. So on that note, Cindy, I'll send it back to you for questions.
Thanks, Michelle. Great job. It shows how much work you've done, but also shows how much work we still have to do, doesn't it? But you know, across the country, we have lots of work to do. But it's nice that we're getting there, and this is the first step. Really, is all about increasing awareness. Have a couple of questions, and please remember to type your questions into the question pane or panel, sorry, in the onto the right of your screen. A couple of people are interested in how they would access your toolkit that you mentioned, the primary healthcare toolkit.
Yeah.
Can you just maybe remind people again of that?
Yeah, it's a shared Dropbox folder. So one of the things I didn't put on there was my email. So I should share my email. It's MM as in Mary, Werstuck, WERSTUCK@gmail.com. And Cindy, maybe that's something that if we're sending out information, we can make sure people have access to that. So currently it's just send me a quick email and then I send you a link to the Dropbox folder.
Very good. Another question here, and actually this is a very good one, and maybe we should have done this right at the very beginning, but it's, can you define primary care in Ontario? I'm not sure it's similar across the country.
Someone's giving me a tough question. Yes, it is very different across the country. So in primary care is considered that entry line where we have that opportunity for early identification and intervention. And so family practice, I'm coming from it from more of a family practice setting, but really, you know, public health, home care, even our dietitians working in retail settings, these are all technically primary care settings as well, right? So this is very much a perspective from the family health team, which is the model we use in Ontario, but there's also family health networks, there's primary care networks, there's FOs, there's all different variations of primary care settings where basically dietitians and IHPs are working together elbow to elbow, providing care to patients. So that's the way I see primary care settings. So our next step with our action group is really to be linking this with other dietitians across other settings, like our hospital partners. We're having lots of conversations of how can we facilitate when these people are discharged that we know who's been tagged as malnourished and we can continue the care plan in family practice. We're also linking with our home care dietitians because, again, it's that question of, you know, how can we make sure people have access to a dietitian to provide that nutrition support. So I hope that answers the question, but you're right. There's very, very many different models across the country. I think the bottom line is really how can we embed nutrition screening into whatever setting we're in so that we can detect issues early and improve outcomes.
That's great. Actually, that's a good segue to the next question. Before I do ask that, though, I just want to remind people, if you haven't already, download the handouts that are on the panel on the right-hand side of your screen. You can find the handouts there. I just wanted to remind you to do that. So you mentioned about screening in other care settings, and we actually have a question, which malnutrition screening tool would be best for long-term care settings? Now, I know you don't work in long-term care, but Just wondering if you know that.
So really, a lot of it depends on what you or your team are looking for. Again, in long-term care, you may have a lot of folks with cognitive issues, so you might want to use the MNA. MNA comes in the regular version, short form version. So again, that systematic review I mentioned by Hammer-Rudin that was done in 2016 does an excellent job at comparing all of the screening tools, and there is many for sure, and that's sometimes the daunting part. So it's called Outcomes Related to Nutrition Screening in Community Living Older Adults, a Systematic Literature Review by Hammer-Rudin. It's in the Archives of Gerontology and Geriatrics. So they have a table there for you that will give you a nice choice menu, pretty much. Many of the dietitians and family health teams, they would want to go for upstream assessment. So when change in intake actually starts to happen, but some of our teams found using the Screen2 as an 8-item tool was too long. So again, it is a bit of a compromise, trying to see what can we use, what will get screening started, and then assess, is it working? Are you seeing positive screens? Is it within your capacity? And then maybe readdressing, is there a better tool that we should be using? I hope that helps.
Sounds good. Yeah, I remember once hearing that almost everybody in long-term care could be considered to be at nutrition risk just for the very nature of why they're there. And so when it gets to long-term care, it's almost like you're looking for a prioritization tool or, a triaging tool. And then you have to find the one that works best for you to find the sort of the higher nutrition risk people. Yeah.
One you could do, because the Screen2 it is a measure of diet quality as well, correct? So you can actually do that as a, pre-intervention and post. So if you actually see an improvement in the score, that would not only help show reduced nutritional risk, but an improvement in intake and access
and is that
to
one,
food. So that's something.
Do you recall if that one's been validated in long-term care setting? I can't.
No. So Screen's been validated in community. And so this is the thing, right? Some of these things have not been validated across sites, but it's always a question of where do you start? Like, what do you start with? What's the one change? Just like we ask our patients, what's the one thing you could do this week that would help identify these vulnerable populations and help facilitate awareness around this population? It might just be, talking with your team about, do we have weights on our seniors? That was an eye-opening for our clinics. We didn't even have weights recorded, sometimes 3-4 years of no weight in the EMR. So it is a question of having, using some of this information to have that conversation, open up the door to sort of say, what do we want to do? What could we do for this population? Where do we begin?
Very good. Yeah, I agree, 100%. Okay, so two more questions here I think we have time for. Two of them relate to the same thing, and then we'll have another one. Most vulnerable seniors live on low income, and do you have any strategies to share about improving access to food for those with limited resources?
Yeah,
good question.
In the community, it's a great question. That is such an important topic because that affects all of us really. But when I'm seeing a senior, we have a food access guide within our regions in Ontario that link to community resources and support. So Meals on Wheels type of initiatives, community kitchens, community gardens, community meals where seniors can go and actually eat together for a really economical price. So that's one of the things we notice. Isolation is a very strong risk factor for malnutrition. So sometimes linking our seniors with some of the services that they just don't know about, and maybe a buddy system so they'll go, work very, very well. The other piece as a dietitian is we spend a lot of time assessing food intake and giving them options of ways to be more economical. Things how to substitute for, buying fruit in season, for example, or buying frozen strawberries rather than fresh strawberries. So, you can whittle it right down to very specific, basic suggestions that'll stretch their food dollar. But we spend a lot of time speaking about that. Yeah.
Okay, a couple more questions about screening tools. So one of them is, how about the screening tool for acute care? Just maybe remind them which one is the most recently validated one for acute care.
So the CNST, the Canadian Nutrition Screening Tool, the 2-question one is the one that's been validated for hospital. I'm trying to go back to it just to show you. Yeah, so CNST is the one that's validated for hospital admission and hospital discharge. And that's the one that was used in the malnutrition study across Canada. And that's the one that they've used at, I think it was over 1,000 patients across multiple clinics within 18 hospitals. So it's been validated for hospital admission and discharge in Canada.
Okay. And I know I said only one, but there's a lot of questions and I really don't want to miss these. So a question about training for SGA, and is that available in the Dropbox? And I think you can probably speak to the
training. So we've done webinars on that, and we've actually had the Canadian Malnutrition Task Force does a tremendous job, and Bridget Davidson sort of leads this, and she'll actually come and do an SGA training, and we use the train the trainer model. So we've had several trainings with her, and every time she comes in, she's wonderful. I learn more and more every single time because many people feel uncomfortable with SGA, and that's one of the things as an action group. We actually had another training session because dietitians told us that they want more practice at how do I do the SGA, how do I start the conversation, how do I know there's been a change, how often do I remeasure? And Bridget said that we should be doing SGA every visit, and if that visit is every 2 weeks, for example, say in family practice, to be redoing the SGA. And the question came up in the session was, how do I know this is malnutrition versus sarcopenia versus cachexia? And what she recommended is do your nutrition intervention, assess whether or not you're seeing positive improvements. Are you seeing an improvement in intake? Are you seeing a stabilization of weight? And that's a positive trajectory. And that you could redo your SGA and that would change the score. So again, she's wonderful. I would encourage you to access the Canadian Malnutrition Task Force for some hands-on training. They do a great job.
Okay, I'll ask one more question here, final one. Do you think doctors have sort of do they have it in their plans to do sort of a nutrition screen with their annual visits with their patients? And if so, do you find in your setting anyway that, do they have these annual sort of screens that they do, or is it something that you've had to have them sort of teach them about, I guess?
Yes, we've had to advocate strongly. So annual reviews are very packed full of things the doctors have to do. And so as dietitians, it takes a lot of advocacy efforts to really put nutrition on the radar. And that's why one of the best things about this initiative is if you can advocate to use a validated tool, it seems to get more buy-in. So the doctors and the nurse practitioners and the other team members seem to be very willing to say, oh, geez, I didn't realize the prevalence, because there is some underlying belief system issues that we have to address, that many people do believe, well, why are we looking at this population? This just happens as you get older, which we now know is not true, that we can help people to age well and not become frail. So there is that evidence, that whole idea of, did you know, by the way, I just saw a systematic review on malnutrition. And so bringing that to their attention sometimes really gets a bit of buy-in. Advocating for validated tools to link with what they're already doing also works well. So if you can get them to do the CNST tool, right now we have our nurses doing it on the discharge phone calls, but I do hear some of my resident doctors now asking about it. So it gives them a framework. They like that sort of, here's a validated tool that they might ask these questions, but maybe didn't ask it in a framework before with an action linked with it. Mm-hmm. So now 2 yeses, they're like, yes, okay, I'm going to recommend a referral to the dietitian for further assessment, including SGA. So it helps give them that process. So I think if we can share the tools and the clinical care pathways with our teams, mm-hmm. they feel more comfortable themselves. And the evidence, right? A lot of it is they're just not aware of the evidence. It was overwhelming to me as well when I started to really hit the literature. It's astonishing how much literature is out there on why we should be focusing on this population. And as an action group, there's many other populations we're currently not seeing in family practice that really are vulnerable. And we will be thinking about, our renal population, for example, and then our patients living with dysphagia. So these are other subpopulations that can be very high risk of malnutrition, that we're going to also be advocating that this now gets on the radar of our team members so we can help as dietitians.
Okay, one more time, your email address, mmwerstuck
at Gmail. So that's mmwerstuck @gmail.com. So send me a quick email. I'll send you the link, and then you can have a peek at the Dropbox and see what you think. And hopefully there's something in there that might be helpful for you.
Okay. Well, with that, we'll end our webinar presentation. I'd really like to thank Michelle McDonald-Werstuck and our audience today for your participation. It's clear that early identification and assessment of individuals at risk to malnutrition in the community is such an important initiative, and it's something we have to do something about to prevent these individuals from declining and being admitted to the hospital. So Nestle Health Science is happy to be sort of a partner in sharing best practices to help tackle malnutrition in all care settings. So thank you, everyone, and have a nice rest of your day. Goodbye.
Thanks, Andy. Bye-bye.
Bye-bye.